Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation, and over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. Somewhere around 10 to 15% of children in this country have sensory processing difficulties. Think about walking into a hospital for a surgery or a procedure. Lots of colors, unfamiliar loud noises, bright lights, lots of people walking around everywhere. Children with sensory processing difficulties can really struggle when coming into a hospital for a surgery. Some really innovative leaders at Children's Wisconsin and Dayton Children's Hospitals have been doing groundbreaking work for years in creating solutions for these children. I sat down with Anita Norton, Lisa Boettcher, and Jill Wiench from Children's Wisconsin and Dr. Sean Antosh from Dayton Children's about their work and the amazing impact they're already seeing in helping children with sensory processing difficulties. So, children who have sensory processing issues often struggle when they come into a hospital. Tell me more about what that could look like and feel like for a child and a family, and what kind of impact that could have on their delivery of healthcare when they come to a children's hospital like yours.
When children come to the hospital, it's an overwhelming environment with lots of new sounds, sights, smells, all different things that they're not used to. And it also takes them out of their normal routine. So, being in the hospital setting is upsetting for a lot of these patients. And we as staff are needing to get our jobs done. And sometimes we have to do it quickly because it is the healthcare setting. And a lot of these patients are not cooperating because it is such a short period of time. And it's not because they don't want to, it's sometimes these patients need a little bit of extra help and explanations and guidance to get some of the care done.
I talk to my kids about when they come to Children's Hospital where I work, and you walk in, it's this beautiful lobby. It's colorful. It's clearly been designed to be useful and comfortable and welcoming to kids. But it's also loud. There's noises. It's busy. There's a lot of people there. There probably are smells they're not used to. There's definitely a lot of light. It could be, particularly for a child with sensory processing difficulties, it could be overwhelming. So, approximately, how many kids do you think that come into the front door of your hospital have some type of sensory processing issue? What would you ballpark that as?
So, in surgical services at Children's Wisconsin, we care for patients with sensory processing disorders on the daily, both at our main hospital as well as our ambulatory surgery center. And we have only seen our numbers increase in the past 3 years since starting this initiative. I would say probably per month, we're looking at 70 plus at the hospital alone, and it's getting up to 30 plus at the surgery center. So, since 2022, at the hospital, it's increased 38%. We continue to track as part of our quality improvement work, and we've had a 47% increase at the ambulatory surgery center, 38% increase at the hospital.
What does that family's experience look like when you realize they're being overwhelmed?
A lot of those parents feel like they're being stared at. People are looking at them because the child is either having a meltdown or a difficult time. So I think as staff, we try to be patient with that. We try to be aware of that. And if we are able to move that patient quickly out of the waiting room into a room so that it is a little bit more private, they're not in the outside waiting room, that's really helpful for those families. And I think with what we've done with our plans and our LCT plans, our Let's Cope Together plans, we've already learned a little bit about those patients that are coming in. So we've reviewed those and we know some of their triggers. So we try to make as many modifications as we can so that they feel a little bit more comfortable while they are here. If that's dimming the lights, if that's having less people in the room, if that's taking the bed out of the room, if that's a trigger for them, whatever modifications that we can make to make these patients more comfortable, I think we really try to be aware of that. And we also try not to overwhelm them if they are having a difficult time by a lot of people surrounding them at one time.
Let's cope together. That's what you call it. Such a nice name. What does it look like today? Walk me through what that experience looks like.
So we put in place, like Jill mentioned, the Let's Cope Together plan. We adopted the name from the ER who had a similar plan going on, and we wanted to keep it uniform within the hospital. Present state, you will get a phone call from our pre-op call center nurses asking about a coping plan and if you would be interested in filling one out for your child with sensory needs or autism. Part of that plan looks at their likes, their dislikes, triggers for them, things that calm them down, and like Jill mentioned again, the sensory needs, things that we can change in the room, lights, noise, bed, any kind of setting changes we can make. We put that plan together and put it in our Epic chart where the anesthesiologist, the nurses, the surgeons, child life, anyone who cares for that patient can see the plan. We also put a sign that says LCT on their patient room to make people aware that a plan is in place before entering that room. These plans can be modified at any time so they can grow with the patient. So if they would have a procedure and we find out something works or doesn't work, we can change that for future procedures. They're also viewable across the children's health system. So if they see a primary care doctor, they can also see the coping plan if they would go for a well check or something like that.
I have a patient who, when I first reached out to mom about the plan, she was a little tentative because she has had a lot of not so positive experiences with her child in the healthcare field, in stores, just taking him anywhere because he does have a lot of energy and he is nonverbal and he's very curious. So I talked with her for a long time and she was very willing to make the plan. We made the plan. He came in. Thankfully, everybody followed everything on the plan for him when he was here. And he did amazing. And mom was so thankful for the plan that she asked for a copy of the plan. She took it to his dentist. She took it to his psychologist. She took it to his school because she felt like that was describing her son in a sheet of paper that is hard for her to explain every time. So she didn't have to go and have to re explain this to us every time he came in. And she's also a mother who apologizes for his behaviors all the time. And I just kept telling her, you do not have to apologize. He is doing what he needs to cope. And every time, because he is one that comes back quite often, every time he comes in, she gives me a call and we'll update the plan. And then she'll want it again to take with her because she really appreciates these plans. And it's made a huge difference for her because it helps lessen her anxiety when she's in the hospital. And it also comforts her because she now feels comfortable coming to the hospital setting where she did not feel comfortable before.
Thank you all for joining and sharing your story. It's great to hear what you're doing and hoping that others follow suit.
Thank you for having us.
Dr. Antosh, I was really surprised to hear about kids with autism spectrum disorder. They come to the hospital more. They are more likely to be hospitalized because they have some sort of injury, some sort of medical need. They're more likely to have the need for sedation or anesthesia than kids who are neurotypical.
So I've been here at Dayton Children's for 9 years now. And when I started, we had a significant population of children with autism come through our doors. What I found was we were doing just a lot of heavy sedation to get them back to the operating room with us to get off to sleep. Because typically we use a mask to go off to sleep. They breathe in anesthesia gases to go to sleep. So it was just kind of standard of care that would give a pre-op medication to help calm them to bring them back. And it actually was two different nurses that worked in our area at the time. One, she had a teenage son with autism, and then another nurse who actually was a special education teacher prior to becoming a nurse that worked with children with autism. And we were just talking because It seemed like the experience was not the best for the patient or the families, of different ways we could actually be involved to improve the process without using medications. And from that is basically we just started doing research and kind of listening to our families, understanding what they were going through.
It's almost like 90% or so of patients before your new solution, but about 90% of patients would require medication to help themselves calm. And so, what did you do?
We interacted with our child life specialists who are an invaluable part of our team. So they have special education in how to take care of children and their developmental needs, and also work in the healthcare environment to bridge that gap of understanding between the child and the medical procedures. So we have developed our coping plans. They're pretty widely sought out at the US. So it's all these things about the child that we need to know. So have they had healthcare experience before? What has it been like? What has worked? What hasn't worked? What's a trigger for them? What sensory sensitivities do they have? Are they sensory seeking? Are they sensory avoidant on every single sense? And then how would they do with an IV placement? How would they do with just any kind of medication? What kind of coping mechanisms do they have? So we're looking at maladaptive mechanisms, or otherwise known as stimming. So do they headbang? Do they pull at things? Do they like to punch? All those behaviors may be distressing to us as healthcare professionals, but to them it's self-soothing. So really we just started with the parents. We figure out all that information from the parent before they even walk through our doors. So we are prepared to know exactly what the child benefits them and what also will be a trigger to them that we want to avoid.
So, you understand that from the parents and you document it. The child arrives, perhaps for their day of surgery or procedure. And then what happens? What happens when they're here?
So now we have several dedicated adaptive sensory rooms. These are preoperative rooms in which the patient waits prior to going back to surgery. What I mean by adaptive is we take all that information the family gave us and we change the room based on all those characteristics of the child. So we're able to change the lights. We're able to either dim them completely, turn them off. We have ambient lighting that we can turn on. If they actually like light, we can turn it up, or we can pick their favorite color on the wall. We can have it change to beats of music if that's something they like. For sound, the rooms are pretty quiet. We only allow one staff member in at a time to decrease that sound amount, but we can give them noise canceling headphones. We can play white noise in there. If they do like music, they can play a boombox or whatever like that. For touch, we're able to change the room in and out as well. We have different chairs they can sit on, crash mats that they can lay on. We can avoid triggers. One of the biggest triggers I find is the hospital bed itself. Coming back to surgery, they know what it means. And so a lot of times we'll actually take that out of the room until we're really ready to go back to the operating room. So that way it's not a trigger for them. It's not something they're thinking about for the next 45 minutes to an hour while they're in the room. So really the rooms we have are changed per patient based on what the parents had told us ahead of time.
Wow, that's amazing. It's really personalizing their environment to their needs. That's incredible. So, they're in this room until they're wheeled into the operative suite. So, they are, in theory, in a much better place in terms of what their needs are until anesthesia is ready and required for their surgery.
To compare it to our typical preoperative room, the bed is in the middle of the room. The child sits on it. Right above them is a LED light, right? So they're sitting in this bed, they're stirring up the light. There's a lot of noise from the hallways. They can bring an iPad with them. We can give them an iPad. Here, they're able to color on the beds with markers that we have. So there is a little bit of distractions for your neurotypical patients, but it can just be sensory overloaded because the light is bright, the sound is a lot, it's a cramped space. So we're trying to change that or make it different for our neurodiverse patients.
So, before you started this program, 90% of patients required some sort of medication. Have you calculated to see what it's like now? Is it making an impact in terms of medications you require?
So routinely now we're less than about 20-25%.
Wow.
So we've decreased it significantly. And what I will say is even when we have to give medications now, it is in a friendlier environment. So previously a lot of that 90%, while they were taking oral medication, sometimes we would have to restrain the child and do an IM injection of another
Mm.
medication. We very rarely do that now. And in those cases, when we do have to do it, it's actually just in a more calming atmosphere and the child doesn't get as worked up as they used to. And honestly, what we hear from our families is what's most impressive. They really enjoy the experience. Now, when we have them come back, they will routinely ask for a sensory room. They know about it. They know their child does better in it. So we try to give that experience as much as we can to those patients.
Is there any outcome that you're tracking post-op? Are they coming out of anesthesia any differently because they're calmer going in?
So we have found that since we're using less sedation medication preoperatively, they're getting discharged home from our recovery room almost 8 to 10 minutes earlier than before. And
Wow.
while that might not seem like a lot, if your child has autism and wants to be in their own environment, that is a significant amount of time. So we are seeing a decrease in the amount of time they're in the recovery room and able to go back home because they're not as sedated.
Is there a world where you ever consider a post-operative sensory room?
So, with the way our facility is built, we have an open bay concept for our recovery room. However, we do have one individual isolation recovery room. And so we do put some of the neurodiverse patients in there that we know would benefit the most. And so we do technically have a post operative sensory room that we're able to use.
That's amazing. With all of this, you're able to get these patients what they need before they even arrive because you're talking to the parents to understand the needs of each individual child. How many rooms do you have?
So we have currently 5 in our main operating room, 2 in our outpatient surgery center, 1 in our procedural unit, and then 1 in our medical imaging and laboratory environments.
That's a ton of
Yes.
space that you're dedicating to this important need.
So we probably see about 6 to 700 visits per year of children with autism, at least just for anesthesia. And so on any given day, we probably have 1 to 5 patients that are utilizing one of the rooms. And we actually have expanded this now. So it's not just children with autism, it's anyone with some kind of neurodiverse diagnosis or oncology patients, anyone with medical PTSD, anxiety. So anything that we know that could cause preoperative anxiety, we use the rooms for them as well.
Has anything surprised you as you've done this project over time? Anything that you didn't expect?
Really, I didn't really expect the decrease in pre-medication. It just was one of the things that we thought we were doing good and then looked at it after the case. That we were noticing that our practice pattern had changed. And it's not because we mandated that we stopped doing pre-medication. It's just we've noticed over time that the kids are doing better and better. So we don't need that medication to take the edge off going back to the operating room.
What's next? What would you hope to do in the next few years as you continue with this program?
So, as an organization, we've already started rolling this out in areas that children have contact with others, such as the emergency room. They're building a sensory room. Our outpatient centers, they have sensory features that can be turned into a sensory room. Because again, if they're coming in for surgery, they had to see a physician first in the office, right? So, how do we maintain that same level of care in the outpatient setting? So, that's happening as well. Our behavioral health unit has a sensory room too for de escalation. And I think the biggest thing that I think about is not necessarily pediatrics, but all of these children at some point are going to turn 18 and 21 and they're aging out of our system. So, how do we engage our adult partners to create environments and care in the same way we are? Because again, while they might be adult sized and adult patients, their mental abilities and their diagnosis of autism still is distinct. And it's a different way of taking care of patients than I think a lot of people are comfortable with or understand. Because in medical school, we don't really learn too much about this, more the social science behind it of how to actually take care of these patients.
Thank you. Appreciate you coming on and congratulations on this amazing success. Truly trailblazing and teaching others how to do this and appreciate you for what you do.
And now for your dose of dad jokes. Why did the mattress go to the doctor?
Why?
Because he had spring fever. How many surgeons does it take to change a light bulb?
How many?
1, but it will take 7 years of residency and $5,000.
More than $5,000.
Why is there a lot of food left over at a scarecrow's Thanksgiving feast? Because all the guests were already stuffed.
It's always fun talking to Missy Krasner. She has this energy that can't help but make you excited about the future. Missy's been everywhere. She's been at HHS, Google Health, Box, Amazon Alexa, Redesign Health, and she's been an advisor and board members to countless startups in healthcare. She's seen the good, the bad, and the ugly of health tech over the past many decades. I sat down with Missy fresh off the JP Morgan conference a few weeks ago to get her take on 2026 and what she's most excited about. What's the general feeling from the industry right now?
I've been in the industry for a long time. I've spent a lot of time in big tech. I was early days in the first Google Health team and did healthcare stuff at Box when they IPO'd. And then Amazon recruited me and was there during the early Amazon Care, Alexa Health and Wellness days. And prior to them buying One Medical and right when they bought PillPack. Now I'm angel investing, sitting on boards and doing a lot of digital health advisory work post my time at Redesign Health. And this was by far in the 21, 24, 25 years that I've been going to JP Morgan. A, it didn't rain, and B, it was very full of excitement and hopefulness, despite the fact that we're in a very difficult time in healthcare today due to cost pressures, labor shortages, regulatory impact, particularly your neck of the woods with safety net. And I would say three things were exciting. One, everybody was running around in the AI buzz, particularly because right when the conference started, both Anthropic and OpenAI announced their D2C offerings for healthcare, which was extremely exciting. The second is that there's still a lot of hope and excitement around the retailerization of healthcare, particularly because of the GLP-1 wave. And there is a lot of cost pressures around formulary. And so there was just a lot of talk around where are we going? How are some of these specialty drugs impacting employer spend, payer spend? Like, what's happening there? The last place was anybody that had a solution or an innovation in cost containment and cost pressure management, whether that's all the unsexy stuff that AI is doing, everything from denials and payment integrity, coding, prior auth, all of it, because people are just looking to save money, save money.
I think scribing is a great example of where the adoption's been so high. So many different health systems are already in contract with so many of these different vendors. The product quality and the value is being delivered to a certain degree. I think that's where the horizontalization of more platform, it's a great opportunity. We'll see what happens, but I think between coding opportunities or rev cycle opportunities on that end, you could take that to optimize workflows and clinical workflows. You could use it to optimize consumer-oriented practices. And there's a lot of things you could do once you have that ambient information, but more so, their foot's already in the door. And the speed by which those solutions hit the market has been really high. Having said that, I was actually hoping for the same thing once telehealth went big after the pandemic, and it didn't really happen, right? I don't think that those telehealth companies who also had their foot in the door really were able to successfully horizontally build platforms off of that chassis. So we'll see. I'm hopeful with describing as an opportunity, but it just depends on how well they execute.
The telehealth really missed the boat on expanding horizontally. And we saw a couple companies try to move from primary care into chronics or into behavioral health or into women's health or into peds even, and haven't seen that uptick. You haven't seen them invest in platform. Like, here's EHR Lite, here's RevPsych, here's scheduling, here's triage, here's digital front door. Like, you could have just completely owned that. And I know a lot of startups that sort of had that vision and for whatever reason just couldn't move fast enough to capitalize on the opportunity or didn't have the right talent in-house, or the AI sort of wind came and they had to refocus and catch up there. So it's a really good example of a missed opportunity.
You brought up from JP Morgan the direct-to-consumer announcements from Anthropic and OpenAI. And for me, for the last few years, all we've been talking about is cost containment, efficiency, enterprise-facing solutions. That's been a lot of the emphasis. I'm excited to see these direct-to-consumer offerings. You've spent a lot of time in this space in terms of the consumer side of healthcare. Where do you think we're going as it relates to those two options of D2C chatbots that leverage LLMs and how it's going to monetize and what the business model is going to look like for those types of things maybe in the next year or two?
I just got invited to write an op-ed on this for Market Watch, and I've been actively posting on this primarily just because I am like the biggest failure in big tech around trying to do this. Like, I did it 21 years ago at Google. I was the first Google Health team. And our idea back then was, hey, all of your personal health information is in these disparate EHRs, PHRs, fitness apps, payer portals, retail pharmacy portals. You know this world so well. The idea was, how do we aggregate all that disparate information into almost like a consumer mediated master medical record patient file? That was 2008 when we launched that. Then many years later, 2018, I think Apple took a sway of it. They were trying to work with you when you were back in your Cedars days on their health record. Really, the idea was, what do you do when you get all that data? Google really wanted to do contextual health search. Now we know a little bit of information about you,
We can do a much better job of giving you answers conversationally and contextually because we know stuff about you. And everybody thought back then that it was like, oh, it's Big Brother, it's privacy. It turns out it's not privacy. Privacy is really about utility. It turns out that people are willing to share their information, even their personal information, if they get cheaper services, faster services, and just streamlined convenience. It's a value chain. You will give more if you get more back. So what were the issues and what is now going to happen with these two services? And it was three things. It was authenticating your identity. Missy Krasner is really Missy Krasner, and it's not four other people with the same name because we have no national identifier. So 21 years ago, that was hard. It wasn't standardized. It was like a nightmare. Next is linking accounts. Oh, I got to link my Walgreens account with my Google Health account. Apple had the same problem. Almost 50% of people don't have a lot of online accounts in their portals. And if they do, they can't remember their username and password to link. We've figured out better linking. Last but not least, is the data actionable when it comes over? Is it doctor speak or gobbledygook? And we know this from my chart. We know this because you live in the EHR over on your side of the woods. It's not actionable. It's really hard to map and keep. And so these are all the reasons why Google Health failed. It's why Microsoft Health failed. There was just not a real business use case for it. Consumers wanted it. They just didn't know how to make it actionable. Today, with LLMs, done. Super actionable. You could literally take all of that gobbledygook, structured or non-structured. These LLMs are going to do that for you. And they remember your conversations. And they both said in no uncertain terms that all health conversations will be stored separately and will not be used for large language model training on their commercial side. It's going to be a whole separate thing. And I know this when I tried to do this at Alexa, and we tried to make Alexa HIPAA compliant and conversationally competent around health and health tasks. Go refill my Ambien at Walgreens.
So do you think that last piece around the actionable tasks, is that something that you would monetize at that point?
Yeah, 100%. It is the exact same third-party app marketplace that Apple's done. Let's say that you're making a decision about a surgery that you need to have. Let's say that your kid was born with some orthoscoliosis. You would use it all the ways that you would use normal Google search, right? So let's say you're looking for an ortho that specializes in peds and scoliosis. You narrow that down, you go see that ortho. It's a surgeon. You do 2 or 3 consults. You get all of the post-visit notes. You get a lot of the information around the procedure. You load all of that up and you get all that organized. And then it might be some of the personal conversations that you've had with your family about the pros and cons of doing it at this age versus another age, what the recovery timeline is. And then essentially you can start having a conversation about what are the pros and cons based on lifestyle choices of us doing this now or waiting until our child is 5. What's the recovery time? And then you can organize all of those thoughts into a template so that you can go into your next visit and just checklist down all the things you want to conversationally talk about. And I think that's really hard to do now because I have to manually download things out of my MyChart portal that don't make sense, they're all in doctor speak. I haven't figured out how to get all the pointers of what I wanted. And then I got to sit down with my family and go around and get everybody's opinion, type everything into a Google Doc, and then walk in, maybe print out that doctor and go through it and manually take notes. It's just so much easier. The time reduction and the data synthesis is amazing. We're already doing it with our family.
The other opportunity, if you think of end user, is also having the interface interact with school-based systems, not for healthcare, but think of mom and dad. They've got their doctor's appointments, their healthcare, their meds, but they've also got all the stuff they've got to deal with their school, their activities, all that kind of stuff. You put that all into one wrapper where this one tool you chat with can basically interact with and perhaps even seamlessly look at all the information. So I have 2 other questions for you. One is you've spent a lot of time in the voice space. I'm talking about your time at Alexa. How do you think that plays a role into this? So much of this currently is very text oriented, but do you think that voice plays a role in terms of how people interact with some of these technologies? Does it matter?
I do think voice, particularly as the LLM gets to know you, you can customize conversationally the tone and the voice. And it's very interesting. My husband, he's gotten a DEXA scan and he has completely customized ChatGPT on his phone with a male voice that's got a particular British accent and has conversationally gotten to know him, and he's fed in his DEXA scan, all of his weight, all of his app work, his diet. And so he literally will have these conversations multiple times throughout the house and during his business day where he's just having a friendly conversation with ChatGPT and it's become a personality. a trusted personality in the house. And I think voice will be the most empathetic and evolved. And we saw that Alexa. I mean, we saw that with elderly folks. We saw that with kids. And you would just have people from 0 to 5 grow up and just think of Alexa as another personality in the house that you could engage with. So I personally am very excited about voice with this new crop of chatbots.
It feels to me like Alexa came a little bit early for its time. Like, I feel like if the entire category was introduced today with these LLMs, perhaps adoption would look different than what it did whenever that was, given the back end of what could be possible in terms of the interaction with a voice AI. I think that's just tremendous.
Yeah, we were definitely early. The whole smart speaker segment was really early for its time. I think Amazon and Alexa led that, with Google coming in second. The problem was the long-term business model beyond the short margins that you would just make on the device itself. And I think where we fell flat is there were really only 3 or 4 use cases that people would use the device over and over for. And it was like very simple things like, talk to me about the weather, give me a news flash, music, very entertainment oriented. Alexa was just scratching the surface when I was there on that, particularly that technology. And then really trying to develop these verticals, like a health conversational vertical.
But the flip end is it got people comfortable talking to a robot, right? I mean, that's core from a behavioral standpoint. So now as we're talking to AI like your husband does, like, it's much more natural. It's not completely a new concept.
Same with the dashboard in your car. I mean, like a lot are comfortable talking to the car. There's not a day that goes by. I still have 20 Alexa devices in my home. I still use Alexa all the time. And Alexa has the new Plus version that is, they're laying in the Nova Amazon LLM, trying to catch up in the market with this new technology. And the hope is that the smart speaker device will evolve.
So my last question is, you've done a lot of work as it relates to services, healthcare services. You listed a bunch of things related to kids and parents and adolescents, but also just the entire healthcare space. Do you think that at some point in the future, more people are going to pay more out of pocket for healthcare services?
I really do. And let me tell you why. I think all of the access pressures, all the ways that employers are getting squeezed in their benefit basket, and just pure medical cost inflation, I think it's going to force people to have to pay more out of pocket. I know at-risk populations don't have that sort of disposable income, but I think people are either going to end up in the emergency room, or people that are dropping insurance are going to try to figure out how to go at risk and get into sort of alternative payment programs around, hey, I've put dental off for a year, but if I can join this discount dental program, I think you're going to see a lot more. The longevity space and the concierge space is going to democratize down to the middle class. We've already seen that with the One Medicals and the Galileos and the first crop of these, even with Amazon trying to sort of really push One Medical now through Prime. I think it's the only way that we're going to fill the gap around care needs, because traditional insurance, employer-sponsored benefits.
I think behavioral health's another space where that could happen too. The need is high, the access is what it is, and I hope that through technology and through other startups that are out there that we can democratize down, just like you're describing for all the other stuff.
100%. Yeah. Huge need.
Missy, thanks for joining us today.
Absolutely. Very fun talking to you, and really excited to see where 2026 lands us. We need the peds out there and the children's hospitals, like, fighting the good fight. We definitely do, especially during these regulatory challenging times, shall I say. Yeah.
Right back at you. We need people like you to help everybody realize the importance of funding these types of companies, backing them, supporting them, helping them grow, because 10, 15 years ago, there was not that ecosystem. So thank you. All right. Thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.